Welcome to Conversations in Tinnitus, a podcast of the American Tinnitus Association. The American Tinnitus Association is a nonprofit organization dedicated to research, advocacy, education, and support for people who live with tinnitus. Conversations in Tinnitus podcasts are an extension of ATA's magazine Tinnitus Today, the only publication dedicated to educating the public and practitioners about ongoing research, treatments, and management of the condition. Welcome to another episode of Conversations in Tinnitus. Joining us today is Dr. JinSheng Zhang, who is a professor in the Department of Otolaryngology, Head and Neck Surgery in the School of Medicine, and jointly appointed in the Department of Communication Sciences and Disorders in the Liberal Arts College at Wayne State University. In addition to his work at Wayne State University, he also happens to be the chair of the Scientific Advisory Committee for the American Tinnitus Association. So thank you, Dr. Zhang, for joining us today for this conversation in tinnitus.
Thank you, Zhang. Thank you, Dean.
So we're here to talk about neuromodulation today. And as we know, that can be a big topic. Neuromodulation can encompass a lot of things. The very basic understanding I have of neuromodulation from a scientific perspective is that we're essentially using some stimulus to make changes in the brain. Is that a fair statement for a very broad sweeping description?
Yes, it is.
From your perspective, what is it exactly that we're trying to do with neuromodulation when we're treating tinnitus? What is our goal for that?
So if we talk about treating tinnitus, there are many ways. And commonly in patients who are looking for a pill, the pharmacology treatment or pharmacological modulation. So and the way we use neuromodulation, in a layman's term, it's a stimulation, electric stimulation, or other type of stimulation, a sound stimulation, or magnetic stimulation, and to modulate and basically the neuroactivity. If we consider that the abnormal neuroactivity, the firing of neurons, and in different parts of the brains that contributed to the problem of tinnitus. So we want to calm down of these abnormally firing activity of these neurons, and so that we call that neuromodulation. So as I said, it has many forms, magnetic stimulation, and we call that transcranial magnetic stimulation. And also there's another form, it's called TDCS, transcranial direct current stimulation, and another one is we can stimulate the brain directly. We call that a direct brain stimulation. The commonly used form of a direct brain stimulation is auditory cortex electrostimulation. And so far, there are a couple of ways. One is they put electrodes extradurally. In other words, these electrodes are not implanted into the brain structure and to stimulate the areas in the auditory cortex. That's the most commonly stimulated area. And the other way is intraparenchyma. And so we implanted electrodes into the target brain area to deliver electric current to modulate those nerve cells in that area. And so it has been published by stimulation of auditory cortex. So we consider the neuroactivity if it is not normally firing. And so we call that, it's a possible the contribution of etiology of tinnitus or to help generate tinnitus, and commonly used in the forms of, we call that, there is a word, the maladaptive plasticity, because our brain is very plastic, and following acoustic trauma, that is the most common inducer of tinnitus, and so they generate the not wanted, not good brain plasticity. We call it maladaptive plasticity, and manifested in the forms of hyperactivity. So the nerve cells in the brain, they fire abnormally higher than normal. So we call that a hyperactivity. And also the neurons or nerve cells, they fire, usually they fire in the synchronized manner, and to perform a certain task, to generate percept or brain tasks. But if the synchrony is abnormally higher, we call that a hypersynchrony. So this is another type of abnormal pattern. And also, in our brain, and it's the brain, they're tonotopically organized. In other words, in the auditory system, in the different part of the brain are responsible for processing the sound of the different frequencies.
Right.
And after the acoustic damage, and their tonotopic map is distorted. So all this is considered a maladaptive plasticity. With all these abnormally change the signals, and that we believe, based on our publications, our colleagues, and my lab, and they considered it to be the causes of tinnitus. So in order to change these abnormally firing patterns of neuroactivity into normal, so we needed to modulate. So that's why we introduced neuromodulation, and by using different forms, as I said, magnetic, direct electric current, or direct brain stimulation to downregulate, to try to make them normal, and aiming to bring down the percept or the sensation of the phantom sound. We call it tinnitus.
Mm-hmm, mm-hmm. I think there are a couple good nuggets in there, what you just said. You mentioned that we use this term maladaptive plasticity. And, of course, people talk about plasticity. There are a lot of people coming out with exercises to try to take advantage of plasticity, whether they truly work or not. But the concept, as I think you're describing it, is that the brain is reacting to something that's happened, but it's reacted in the wrong way. And because of that, we have this tinnitus created by stimulation in the auditory system that's not supposed to happen. Is that fair?
That is correct.
Okay.
Yeah, that is correct.
And so, and of course, we're hearing a lot about different forms of neuromodulation right now. We're certainly hearing a lot about transcranial magnetic stimulation. There's a fair amount of research coming out on that right now, as well as the other methodologies that you mentioned. But essentially what we're trying to do for all these different procedures is kind of disrupt those pathways and hope that they will then recover in normal fashion. Is that correct?
That's right. And over the last approximately decade, there are lots of clinicians, scientists, especially clinician scientists, they can access to human subjects or patients to examine the therapeutic effects of these modulations. And in the animal research, for example, my lab, we put electrodes in the auditory cortex. We're able to downregulate the spontaneous firing in the auditory cortex by stimulation of the auditory cortex. At the same time, these animal subjects, we use a rat model, and we see the behavior evidence of tinnitus after noise trauma, and the most common inducer tinnitus. And then as soon as the behavior evidence of tinnitus appeared, we exert electric stimulation of the auditory cortex, so we can suppress the behavior evidence of tinnitus. So we provide the the evidence from animal research, and basically support what has been found in the clinical setting or in the human studies. And here, I should have pointed out that the audience, and especially the patients, that when we talk about therapies, and so that prompted me to bring up the paper published by Dr. Rich Tyler in the cluster analysis. In other words, So not every patient can benefit from one single treatment. So this treatment may work for this patient, may not work for another patient. So that's what I'm going to say. And with that said, we see a lot of variability in the therapies and the studies of using the neuromodulation or all kinds of magnetic stimulations or brain stimulations. So that's why this motivation and rationale for the scientists in the using animal model to study the underlying mechanisms, why it works and why it doesn't work. So although we published and we demonstrated the evidence by stimulation of certain brain areas, but we have not come to a deeper level. For example, and in the brain, there are lots of neurons and nerve cells, and there are lots of connections between different type of neurons. And so we need to do a finer job by teasing out which neurons and which their connected neurons forming the neural pathways are responsible for the problem of the tinnitus, and also stimulation modulating what neural pathways or what particular neurons. In other words, we use a probing or modulate and target particular neurons, and to be more specific and to generate the optimal therapeutic effect. In fact, there is a new technology. It's called optogenetic technique. Basically, we transfer a gene that express the opsin that is sensitive to a certain light, and so can target a certain neurons to determine whether a certain neurons by stimulation and that a particular neural pathways can generate optimal or better therapeutic effect, and that is under study. We have not found the definite result. It's an early stage of our study. So this is basically along the line of neuromodulation and how is it evolving and what is the current the state of science, the state of clinical results, this current situation.
I'm listening to all this very good information, this waterfall of information, this scientific data that you're continuing to collect. Have you started to get a sense of how you could tease out which method would be optimal for certain fine variabilities of tinnitus or severities? Are we still too early in stages to try and determine things like that?
Yes, thank you, Dean. This question prompted me to touch on another part of this area, and right now we have NIH funded a project by testing the therapeutic suppressive effects of tinnitus through cochlear electrostimulation. I'm sure your audiologists are pretty familiar with cochlear implants. So basically, we have an animal model. We implant the cochlea of the rat. We use a rat model. And so why I bring this up, basically, you can see the cochlea, and it's the peripheral, it's the ear. It's not the brain, right? Mm-hmm. But it's connected to the brain.
It certainly is.
It's the beginning of the auditory pathways, right? We, with a normal ear, can collect the sound signals are transduced and converted to electric signals, encoded in neural impulses, and forwarded to the brain to generate sensation and perception and of the presence of characteristics of the sound. And we know that basically, so to introduce a little bit to the background of the cochlear implant, because we touch on the, in some audience may not be very familiar with this subject, because for certain patients, if they're hearing impaired, we usually prescribe hearing aids through the sound amplification to help them. But for patients, their hearing cannot even be helped by using hearing aids, and they lose a lot of hair cells, even we call that auditory nerve fibers, and that send forward the signals from the cochlea, the ear, to the brain. And there are fewer and fewer the auditory nerve fibers are left. So and normally prescribed the hearing aids cannot help. So we use a cochlear implant to stimulate, artificially stimulate, bypass the myofunctional cochlea of the ear, directly stimulating the residual viable auditory nerve fibers and to deliver the coded electric signals so that the patients can hear.
Right.
So because of the clinical observations and from cochlear stimulation, and by the way, if the restore of hearing through the cochlear implant, right. I'm sure, and you probably also deal with the patients if cochlear implants cannot help restore their hearing. So you bypass the cochlea by directly put electrodes into the cochlear nucleus. So that's the lower part of the auditory brain, in the brain, right, in the cochlear nucleus.
Right, so a brainstem implant is what they usually term that.
Brainstem. That's right. We've been touching on. We publish all these in these subjects, and that help to give the audience a bigger picture of how we approach the neuromodulation. So back to the cochlear implant, you electrically stimulate the auditory nerve fibers, and the clinicians and the patients, they together found out there are lots of patients, their tinnitus get helped.
Yes.
So this bring about lots of excitement of this. The question, what's going on? So basically, recall we just talked about the mechanism or what caused the tinnitus because of the abnormally firing neuroactivity mentioned, the hyperactivity, hypersynchrony, or even increased bursting activity or distorted tonotopic map or maladaptive plasticity. So in addition to taking the brain stimulation we called from the top and down, and based on the pathway projections directions, because there are lots of complex, we cannot say single is only top down or bottom up. So there is constantly up and still down and up. So we talk about the ascending pathway stimulation of the cochlea. And we also found lots of modulation and suppressive effects or therapeutic effects of tinnitus. So this is ongoing. We're finishing up collecting the data. I can update that with you and with the audience that we first implant the cochlea, and we demonstrated that they have a tinnitus after noise trauma. And then we demonstrated about after electrostimulation of the cochlea, their tinnitus can be down-regulated. In other words, their tinnitus can be helped and suppressed. And at the same time, we have the electrode arrays implanted in the auditory cortex. We can record those abnormally firing patterns, and basically with we call that signals or neural signatures of tinnitus. We found the suppression of tinnitus was accompanied by downregulation or decreased spontaneous firing, and also the decreased synchrony in the areas in the high frequency region, because we stimulated the basal term of the cochlea. Basically, we stimulated the high frequency region in the cochlea. We call it the tonotopic, right? And in layman's terms, we process the different frequency, low and high. So. And also we published another one in the paper a few years ago that showed by chronically implant into the dorsal cochlear nucleus, and we suppressed the behavior evidence of tinnitus in rat model. And if you recall that in 1992, Susiato, they published in patients, and they tried to use auditory brainstem implants to restore hearing, and they implanted 11 patients, I recall, and 7 out of the 11 patients, they found not only their hearing restored, but at the same time, their tinnitus prior to brainstem implantation, the tinnitus, their tinnitus was measured, and after implantation stimulation, their tinnitus get helped a lot. So you can see the animal model and human studies, they can parallel. And so plus this is the cochlear implant, dorsal cochlear implant, brainstem implants, and the auditory cortex stimulation. So all consider is neuromodulation, right?
Sure.
Back to the subject we're talking about today is to modulate and change, right? So change those abnormally firing neural activity in the brain, either through the top-down approach or from the bottom-up approach. If you consider, and these are probably, we consider this as invasive. Of course, it's the scientists' job and clinicians' jobs to make further improve this approach, make them less and less invasive compared to another stimulation, sound stimulation. In fact, back to the essence of the working mechanism, is still modulation is the most conservative and less non-invasive approach is through the sound stimulation. All taken together, we call that neuromodulation, and to change the abnormally firing pattern of neural activity in the brain with the goal to suppress tinnitus, to help patients' tinnitus symptoms.
Sure. And in talking about those different methods of stimulating, whether it is a top-down approach, stimulating at the cortical level and having an effect, or bottom-up from the ear, how long-lasting have these effects been found to be once the treatment is stopped? Is this something where people may have to undergo this for a very long period of time? Do the effects tend to be persistent and permanent? I do know that there are some people, speaking of those with cochlear implants, who have wonderful tinnitus relief when they're wearing their cochlear implant, but as soon as they can take their cochlear implant off, it comes back. So for all these different treatments, what have you seen in the literature is the long-lasting effect of these?
Yes, remember we talked about the variability across patients. I think I brought up Dr. Rich Tyler's papers, cluster analysis, so it's up to the clinicians and scientists to do a better job to better diagnose the problem, the real etiology, what causes tinnitus of this patient, so that we can titrate a certain treatment with a targeted to have a longer lasting. So that is a still open question, and in the clinical data, and so yes, some patients, when for example the cochlear implant, as soon as the stimulator just switch down, the tinnitus disappear. As soon as certain patients, as soon as the stimulator just switched off and the tinnitus come back. But for some patients, their tinnitus, even you stop stimulation, and their tinnitus disappears, and for a longer time, hours and even days. I don't recall, maybe a week or so. So this is the range, and certainly it's our goal, and to prolong the lasting suppression of tinnitus. And how to do that. And so we need a better understanding the underlying mechanism of what causes tinnitus better. And then we develop a more targeted stimulation, maybe in combination of a certain compounds, the medicine. So basically electrical and chemical modulation, and to prolong the lasting suppression of tinnitus.
So is that the next step for us in researching tinnitus treatments? Is it going to be combining pharmaceuticals with some of the other methods that we've discussed here?
Yes, exactly. And so the animal model, there are a couple papers there. It's just still understudied. That's why we needed to pursue further. Very, very excited about this research and the data we're trying to publish, what we got, and to share the knowledge with the colleagues and the general public. And So definitely the next step, in addition, you first figure out what's the best stimulation, electrical stimulation alone, and to generate optimal therapeutic effect. And we need, as you just mentioned, to find some chemical and compound and to generate a better, a more potent, more robust suppression of tinnitus. Exactly, that's important. And we just mentioned, we use the word maladaptive plasticity, and so it is generally the case in the clinical practice. And the history, the longer history of tinnitus, the more difficulty to receive the stronger therapeutic effect. So, so ideally, we want to conquer that and to use a more powerful modulation approach and to change the causes of the tinnitus and to generate a more and a longer and more robust suppression.
And even circling back around to Dean's question earlier, us as clinicians, one of our thoughts is, do you see a day when we may do a test battery, maybe including fMRI or other procedures, look at the type of tinnitus, the type of sound it is, who knows what it will be, but have some kind of a process to then say, well, then this treatment looks like it would be the best one for you based on what we're finding?
Yes. We call that is a biomarker or diagnosis. And currently, your clinicians, we all agreed that there is no reliable objective diagnosis of tinnitus.
Correct.
So, and our colleagues in the field using MRI and MEG, and which stands for magnetoencephalography, and EEG, and to figure out what exactly the signatures of tinnitus. And there are lots of publications, there are lots because of the complexity of the tinnitus etiology, and there's no standardized or consensus that shows a certain area, the particular light up in certain brain area represented tinnitus and what type of tinnitus, and it is still the research and development is still is ongoing, and but so far the field have generated lots of information and basically suggesting those hyperactive, abnormally firing neural activity. And in the different part of the brains, we talked about the auditory systems. There's quite a complex already is by itself. But in addition, and there's another important area, we call that a non-auditory structures, and especially the limbic structures that are responsible for the storage of the signals, the tinnitus signals developed and stored in the brain. For example, hippocampus, amygdala, and also responsible for the emotional aspect of tinnitus, and also the tension. And for example, the dorsolateral prefrontal cortex is all these areas are very important in the manifestations of the clinical symptoms, clinical problems of tinnitus. And because of these areas physiologically, they're responsible for storing the tinnitus signals and developed and interacted with the auditory system. And so in order to generate the manifestations of tinnitus. And so you consider that, and so the neurosignatures of tinnitus are still being developed, and the scientists in the field are working very hard to fine-tune, to narrow down, and so that the treatment or optimal treatment strategies can be better developed. And so if you talk about the etiology, not only involve the auditory system, but also the non-auditory and limbic system, limbic structures. So for the neuromodulation, back to our topic subject today, is not only targeted the auditory system, but also the non-auditory systems. So if you talk about the non-auditory system or limbic system, so we generally consider that the reactive system. So in other words, this in the brain and the presence or the activity of these brain structures are determine how the brain reacts to the signals. If the signals of tinnitus showed up, but if our brain, this part of the brain, and basically do not respond to strongly, now, then the clinical symptoms are not that severe. So, and that's maybe this helped explain those type of population, tinnitus populations, whose tinnitus are not debilitating, not bothersome. But on the contrary, if this part of the brain react heavily, excessively, and that's what we call that debilitating and cannot tolerate. So, and the clinical intervention is then needed. Then, if you think about the working mechanism and these two parts of the brains, auditory and non-auditory, so we need to work on both. If we work on the auditory part of the structure, and that can solve the problem of the generation of the tinnitus signals, as we can solve the generation origin of the tinnitus signals to have tinnitus in the first place. Then if we cannot find the best modulation in the auditory system, and so we can work on the non-auditory, the limbic system. So there are lots of options if we can mitigate and diminish the reactions of the limbic structures and non-auditory structures that respond to the presence of tinnitus signals generated in the auditory system. So we can also have a hope to generate a effective therapy for this type of patients. So you can see by taking together, there are lots of ways to manage tinnitus through neuromodulation that can generate lots of hope to our tinnitus patients. And we just need a time and need a better research and to give a better and shorter answer. That's what the patients are looking for.
Well, a shorter and a more specific answer, and I think that's the point. And real quick, Dean, before you ask your question, I just want to echo what you said about the diagnosis. Tinnitus is not a diagnosis. Tinnitus is a symptom. We can't diagnose it because we don't have the knowledge yet to describe exactly what is causing that tinnitus, and someday we will. We don't know when that is, and I don't say that to dishearten people who are listening, but hopefully just the opposite, to underscore the fact that this is so very early in the process, and this does take time. And it can take quite a bit of time, and we're going to stumble, but we're going to learn, and we're going to keep learning and probing, and we will find these answers, and we will be able to get people these help. And someday our grandchildren are going to look back on the things that we went through with people having tinnitus, and they're going to wonder how anybody survived that. Because the cure, the answer is so simple, as it will seem for them at that time.
Yeah. And I also want to comment the wonderful word you used in describing those things at the very end, that we're working hard, but there's hope. And when you have hope and you work hard, all of these answers, all of this clinical data that you're working on and collecting, it is going to congeal someday into very positive things where we can make a difference in people's lives. And you should be commended for that. I thank you for that. That's wonderful. I know that it's still going to take a long time, but it's very nice for John and I to hear and read all of these articles. Especially, they felt like they have accelerated over the past 10 to 15 years, where we're collecting much more clinical data to try and get a real better picture of exactly how we can classify and treat tinnitus.
Exactly. I appreciate your comment, Dean and Zhang. It is it's a great platform for us here to have such interactions with clinicians, with you, and me as a scientist. I just let you know that certainly why we do it in an animal model, because we cannot do lots of things in
right.
animals, human subjects with that we can do lots of things in animal subjects, so we can find more information so that we can translate the know-how into the clinical trials. And I can share with you, we have a number of projects going on in my lab. In addition to my colleagues in the tinnitus field, everybody's working hard. Once we go to conference, we have lots of exchanges, and basically we not only try to pursue the understanding of the underlying mechanism of tinnitus in order to better tease out what causes tinnitus and have a better develop the so-called the neurosignatures, basically the biomarkers in the clinical. Basically, we need to find objective diagnosis. Once we have the diagnosis, and basically that's what the doctors need to do, and then you can exercise a treatment. And we have a clinical trial right now and develop drugs and medical devices. There are lots of exciting things are going on in my lab alone. And I'm sure, and with the ongoing efforts from my colleagues and clinician scientists and basic scientists around the world. And so with ATA, this provides such a wonderful platform so that our audience can access all this information through such a conversation. It's wonderful, and we work together and find the answer.
And so we've been talking with Dr. JinSheng Zhang, who is, again, a professor in the Department of Otolaryngology, Head and Neck Surgery in the School of Medicine, and jointly appointed in the Department of Communication Sciences and Disorders in the Liberal Arts College of Wayne State University, as well as us having the honor of having him serve as the chair of the Scientific Advisory Committee for the American Tinnitus Association. So thank you so much for joining us today.
You're quite welcome, Dean and John.
And again, I'm John Coverstone, and with me, my co-host, Dean Flieger. We are honored to join you as well. Thanks for listening to this Conversation in Tinnitus, and we look forward to speaking with you at the next one. The American Tinnitus Association is a nonprofit organization dedicated to research, advocacy, education, and support for people who live with tinnitus. Gifts and donations to ATA are used to support research for a cure and other critical missions described on our website at www.ata.org.